Welcome everyone to the Malaria Partners International webinar series and today's event, Community Health Workers, an Unstoppable Workforce. My name is Ariel Delaney. I'm the Deputy Director with Malaria Partners International, formerly Rotarian Malaria Partners. This webinar is part of an ongoing series which aims to engage both Rotarians and the malaria prevention community on unique topics of interest made accessible to everyone. The mission of Malaria Partners International is to engage Rotarians around the globe in the fight to eliminate malaria. Our moderator for today's event is Maria Nelly Pavish. She is a human capital generalist, organizational development practitioner, and grant manager. She works for the Inter-American Development Bank in Washington, D.C. as a talent management special programs lead. As a longtime Rotarian, she is a member of the Rotary Club of Washington, D.C., serves as senior advisor of her club's International Service Committee, and is board member of Malaria Partners International. I'll now hand over to Maria Nelly to start the event today.
Thank you, Ariel. I appreciate the introduction. On behalf of Malaria Partners International, I am honored to moderate today's webinar, in which we will be discussing the life-saving and proactive role of community health workers in preventing malaria. Let's look at malaria as a scourge. So malaria is considered the greatest killer of humankind. It kills about almost 500,000 persons per year worldwide, with 250 million cases recorded per year. 17% of all deaths are in sub-Saharan Africa. Children under the age of 5 account for 67% of all deaths. That is to say that one child every 2 minutes dies from malaria. Malaria Partners International is a non-profit organization run by Rotarians and community leaders. We focus on advocacy within the Rotary community and on projects and large-scale programs in the regions where malaria is most prevalent. Malaria Partners International works in close alignment with the national malaria control programs in endemic countries and has established chapter organizations like in Zambia and Uganda. Our efforts in concert with our strategic partners can reduce malaria morbidity and mortality through multifaceted efforts at the national, provincial, and community level. We work to ignite an international Rotarians campaign for the global eradication of malaria. We advocate for support of malaria elimination through presentations at numerous Rotary clubs throughout the US and Africa. In addition, we participate in international malaria advocacy events to bring visibility and funding for malaria prevention and treatment. Our vision is that malaria is eliminated worldwide. On March 9th, Rotary International, World Vision, and the Bill and Melinda Gates Foundation announced the launch of our first program of scale called Partners for a Malaria-Free Zambia, which is a $6 million investment to train, equip, and deploy community health workers in Zambia. This new program aims at eliminating malaria for 1.3 million Zambians and will train, equip, and deploy 2,500 community health workers to test, treat, and educate villagers about malaria. While COVID has been center stage for the last 15 months, over 228 million people contracted malaria actually in 2019 alone, and about 409,000 died, most of them young children. This program aims to end the scourge of malaria in 2 of Zambia's 10 provinces. With that introduction, I'd like to now introduce our distinguished panelists. We have Dr. Madeleine Ballard, and she's the Executive Director of the Community Health Impact Coalition, a field catalyst created by health practitioners in 30-plus countries to make professionalized community health workers a norm worldwide. She's also an assistant professor at the Ikahan School of Medicine at Mount Sinai. She holds a PhD in evaluation science from the University of Oxford as a Rhodes Scholar and was previously the funding program manager at Last Mile Health. She currently conducts research on the effects of interventions to improve the performance of community health workers and works with the coalition to accelerate the adoption of high-impact community health systems design. Welcome, Madeleine. Now we go to Nima Diop. Nima Diop serves as an institutional partnership manager at MUSO. She's based in Bamako, Mali. She's originally from Senegal and attended university in the United States and the United Kingdom, where she received her master's in global development and Africa from the University of Leeds. With a passion for international development and in power of disenfranchised communities, she has a diverse background in international trade and analysis, food security, and speaks 3 languages. Welcome, Nima, to this panel. We also have, now we go on fly all the way to Zambia, from Mali to Zambia. Agnes Phiri, she's an environmental health officer and malaria focal point person under Ministry of Health, working in the Masaiti district in the Copperbelt province in Zambia. She supervises and undertakes the malaria control and elimination services in the district in order to eliminate and prevent the reintroduction of malaria in the Masaiti district. She supervises and undertakes the provision of environmental health services and programs in the district in order to improve sanitation and prevent diseases. She graduated from the Lusaka Apex Medical University with a bachelor's degree in environmental health sciences in 2018. After graduating, she worked with Lusaka Water and Sewage Company for 6 months. Before coming to Masaiti district, she worked at Chitambo Missionary Hospital in Serenje district, central province of Zambia. Welcome, Agnes, to this webinar. We also have next and joining together, Helen Capella. Helen Capella was born in Masaiti, Zambia, and did her primary school education at Mulwani Primary in Livingstone and her secondary at Lushanshwa Central. She currently works at her father's farm as well as with the Zambia's Ministries of Health as a community health worker and also as an integrated case management provider in the province. Welcome, Helen. Great to have you here. Last but not least, we have Dr. Frederick Kaoma. He is a member of the Rotary International and has been involved in the project design, management, evaluation of educational, water, and sanitation and health projects, including malaria eradication. In 2010, he served as the first chair and founder member for the Malaria Partners Zambia, that then named Rotary Malaria Partners Zambia. He currently serves on the board where he's the chair for the MPZ Technical Committee. Dr. Kaoma has served as a doctor in both the urban and rural areas of Zambia and has seen firsthand the ravages of malaria. As the medical manager of the local mine hospital, he is in charge of the biggest effort in eliminating malaria in the districts. So with that, no further ado, that is introductions to our panelists. Let's start and hear from Fred. Fred, can you tell us about Rotary International and its role in malaria prevention and treatment?
Good evening, one and all. Rotary International is a global network of more than 1.2 million members. The members belong to individual clubs hailing from all around the world. Most Rotarians are like-minded people who relish problem solving at work and within their communities, where they see that people should unite and take action which will create lasting changes within their communities, globally, and of course, as a Rotarian myself, in ourselves. Above all, Rotarians believe good healthcare is everyone's right. Yet, despite this, more than 400 million people around the world cannot afford or do not have access to basic healthcare. This is even more so in my own community and most of sub-Saharan Africa, the area where I'm actually talking from. The Rotary Foundation has for many years funded health, maternal and child support, and sanitation projects worldwide. Many clubs, that is the Rotary clubs in the developing world, have been recipients of funding and technical assistance from clubs in the more developed world, which help to set up health initiatives, including a lot of malaria programs and projects. Through Rotary action groups, including the Rotary Malaria Action Group, projects and technical assistance has been advanced to combat malaria. And I think until the establishment of Rotary Malaria Partners, the Rotary Action Groups, the Malaria Action Group was the most formidable one. Currently, the Malaria Partners International In Malaria Partners International, Rotarians have found a voice and action to assist close the gap and help eradicate malaria. I think in a very similar way that Rotary helped close the gap on poliomyelitis as part of the Wide World End Polio campaign. In Zambia, the initiative has supplemented the malaria eradication campaign of the Ministry of Health, that is the ministry which runs most of the health centers, through funding and support to train the healthcare workers, who in turn will bring diagnosis and treatment of malaria as close to the people in the village as possible. I submit, Maria.
Well, thank you so much for giving us this context, Fred. And so we'll now move to Madeline. And I will ask Madeline if you can tell us a little bit about the organization that you lead, the Community Health Workers Coalition.
There we go. Thanks so much, Marianelli, and thank you, Dr. Fred, for that great introduction. So as Marianelli explained at the top of the call, the Community Health Impact Coalition is basically just a team of health practitioners working in about 40 different countries who've come together to make professionalized community health workers a norm. And what do we mean by that? By this, we mean we want to make sure that lay people trained to provide health services in their communities, like Helen, are equipped, supported, and paid to do so. We mean embracing common sense approaches like, again, providing pay, continuous training, coaching that help community health workers and therefore community health worker programs reach their full potential and make sure that all patients, including those with malaria, get the quality health care that they deserve no matter where they live. And so we'll talk more about what some of these practices look like a little bit later in this webinar. But basically what we do is we one, research practices that lead to quality care delivery. Two, we accompany partners to update or adopt their standard operating procedures so that their practices align with these best practices. And then we treat crises like the current crisis with COVID as an opportunity to strengthen CHW professionalization and strengthen health systems so that they can, not only fight pandemics, but as Maria Nelly said, continue to provide essential health services like malaria care, even when times are difficult.
Well, thank you so much, Madeline. And so with this, we'll move to travel back to Mali. And we'd like to ask Nima to tell us a little bit about MUSO. Yes.
Awesome. Thank you so much. All right. Thank you, everybody, for joining this call. It's really a pleasure to be a part of here with all of you today. So as Maria mentioned, I'm the Institutional Partnerships Manager at MUSO. And MUSO, we essentially work very closely with our government partners to help strengthen health systems through the removal of barriers to care. And we do this through providing technical assistance to the government, to the Ministry of Health specifically, and through providing direct service through a proactive model of healthcare that we've initiated here in Mali. This is on the basis of our belief here at MUSO that no one should die waiting for healthcare due to the lack of accessibility that can be either geographic and that many times can also be financial. A lot of patients either cannot get to the health centers or they just simply do not have the means to pay for the healthcare fees that they will be confronted with. And on top of the technical assistance and the model of healthcare that we provide, MUSO's work is really embedded in research. So in 2016 and 2017, along with the Malian government, we together launched at our 8 new sites in rural Mali. We initiated the proactive community case management trial, which tested the impact of proactive care, where we were able to see really the benefits of this model. So essentially, we train and deploy 424 proactive community health workers, paid community health workers in peri-urban Mali, in a populous area called Yirimajo. And we also work in 8 sites in rural Mali in the Bankas region, which is a region that has actually been confronted with insecurity. So our community health workers serve 210,000 patients in Yirimajo and 140,000 patients in Bankas, where essentially they go door to door to provide care for malaria, malnutrition, family planning services, vaccinations, and others. Now, these CHWs, they actively seek out, diagnose, and treat malaria, particularly with children. And now, lastly, I will just note that we're also expanding our geographical reach. After more than a year of providing technical assistance to the Ivory Coast government, we have been called on by the Ivorian government to set up shop in Cote d'Ivoire, and we're currently doing some landscaping analysis to assess the sites where we will be setting up our operations. And to date, we've conducted through our CHWs 7.4 million home visits and 800,000 clinical visits. Okay, thank you very much.
Wonderful, Yima, to see the expansion of MUSO, including also the Cote d'Ivoire, and we hope you're going to tell us a little bit about that later. Now let's go to Masaiti, Zambia, and here we have Agnes and Ellen who are joining together, and they both work for the Zambia Ministry of Health in different capacities and are on the ground every day fighting malaria. So let's start with you, Agnes. Can you share with us a little bit about the incidence of malaria in the Masaiti district?
All right, thank you. In Masaiti district, Masaiti is a rural district and highly burdened with malaria cases. And regardless of it being highly burdened with malaria cases, we still have seen some change after the training of the ICCM and also use of other interventions in the elimination of malaria, such as IRS and MASA, IRS as well as ITM distribution. When the ICCM providers were trained, that was in 2019, and they started even working. We thought of trying to compare after the training and also how the instances are, where we compare the 2019 when they were trained and also 2020 when they are now full-fledged, as in they're fully engaged in the program. If we compare the incidences in terms of malaria, like we have about 41 facilities in the district, and the incidences, like for 2019, the picture for Masaiti district hasn't been that good. And from what we can see on the table on the left, what is there is the number of malaria cases based on the color codings. We call them under color codings, where they are coded according to the colors. So for we have about 3 facilities that are in light red, and the rest of the facilities are in dark red. The ones that are in dark red means these are the malaria instances that were above 500, per 1,000 population. And when you look at our map, it's nearly each and every clinic, each and every facility, apart from the 3 facilities. And that was the picture for 2019. But when you look at the picture for 2020, what is depicting is there's a slight development or a slight improvement in terms of the reduction in terms of incidences. Like when we compare 2019 and 2020, what we have under 2020 is different from the 2019. The number of facilities have gone up in terms of the incidences that are between 200 and 499. That is the ones in light red. And then the ones that are in dark red, those are the cases that are more than 500. And if you compare the two, in 2019, we had about 3 facilities that qualified to have incidences between 200 and 499. But for 2020, we are actually progressing to the elimination of malaria. We have about 5 facilities that have recorded a number of incidences of between 200 and 499, while the rest of the facilities are still in dark red. So it's to us, we may say there's progress in terms of malaria reduction as compared to the way it was in 2019 and probably even before the ICCM providers were trained. On the ground that when these people are trained and they started working, they are able to, when they have a patient, that is a passive case, when they have a patient and when they make follow-ups, they're able to interrupt the transmission of the disease. Since those that are followed up as the indexes, they are even treated when they're found to be positive, thereby increasing on the number of people with increasing the number of people in terms of those that can be prevented from further getting contracted with the disease called malaria. So that interruption has also helped us even on the number of malaria cases as a district as compared to the 2019 picture when they were just trained.
Thank you, Agnes, for bringing us to speed on what's happening in Masaiti. And here we have Helen, our community health worker, and she works in this area. And I'd like to ask you, Helen, which facility and the zone are you working from? Which facility do you work?
Masaiti Boma Health Center.
Masaiti Boma, and I hear that there's a lot of a very big distance for you to get around. So how do you get around every day? It's about, I don't know, how many kilometers do you have to actually travel every day to do your work?
It's 30 kilometers.
And how do you get around?
I use bicycle.
Bicycle, so that means, Helen, that you bike every day, 30 kilometers. So you're not only a community health worker, you're a big athlete. So congratulations for that. And as we try to understand what's going on in Masaiti and your work, we commend your work on doing that. So thank you, Helen. And now we are gonna just move back to Fred. Can you share with us about the training curriculum of community health workers in the Copperbelt region and how the Rotary Foundation Global Grants is supporting the strengthening of these networks in Zambia?
In Zambia, just like in most of the tropical areas, apart from maybe a few island places, malaria is here in Zambia is responsible for more than 50% of all our infant deaths and 20% of the deaths in the women, in the maternal mothers, or rather the women in childbearing age. For the curriculum itself, our community health workers receive about 6 days of intensive classroom training. This is now followed by 1 additional day in the field. And then thereafter, we assign them to the health post or the health clinic where they will spend the next 6 weeks. Of course, these health posts are usually the ones that may be closest to their homes. At the same time, we will equip the health workers with rapid diagnostic tests. These are the ones that are used to test for malaria and make a diagnosis. We also equip them with anti-malaria medicine, usually an artesunate combination, and this ensures that there is prompt treatment. Of course, we want to make sure that once somebody is diagnosed with malaria, the treatment ensures soon after. And then, of course, we also give them lancets for finger pricking to draw the blood for the tests. Infection prevention control is also very much part of the training because, of course, we don't want them to get infected and for the patient to get some other infection which they may have. Just like was mentioned by Ellen, the community health workers also receive robust bicycles, and these help them to navigate the narrow paths from village to village or from post to post so that they can reach the most remote of the communities. They also will receive mobile phones. These are the cellular phones which help them in communication with the clinics so that as quickly as they are able to make a diagnosis, they also report that to the nearest clinic. And of course, the other reason for the phones is to ensure that they share case management data within the national health system. And this also helps. I think you saw the map which was shown, the one on the raids. So all that information will be, because of the phones that they have, they send the information to the center, and then the center is able to populate the cases. As you have mentioned earlier, Maria, the new program of scale, Partners for a Malaria-Free Zambia, is one that will strengthen the national health system by working very, very closely with the local health officials, of course, the local leadership, the chiefs, and then the health facility staff. Most significantly, it will also help to train and equip more than 2,500 community health workers Of course, these will be doing the same duty of testing, diagnosing, and treating malaria. But I must hasten to also indicate that the curricula also teaches them about diagnosing diarrhea diseases and upper respiratory tract infections, especially influenza and such things, because one way or another, these are also some of the most common killer diseases in the tropical world. For more than 10 years now, Maria and team, international Rotarians, that is international Rotarians like Maria herself, Mo, and many, many others, have been working with the local Rotarians here in Zambia with support from other organizations, including MPZ, that's Malaria Partners Zambia, of course, Malaria Partners International, to which you yourself, Maria, belong, PAF MASEPA, the Zambia National Elimination Center, which is a department in our Ministry of Health, World Vision, as has been mentioned before, and of course the Bill and Melinda Gates Foundation, to whom we are all very greatly indebted. I submit, Maria.
Well, thank you, Fred. It's amazing to see what partnerships can actually do and how, by leveraging those partnerships, how we can escalate and actually really see that this goal of ending malaria in Zambia is possible. So with that, we move back to Medellin, and we'd like to get your perspective on the sustainability conversation, Medellin. In your opinion, which are the most critical design principles of community-led health systems success and why?
Thanks, Marianelli. I think the most important thing to understand about community health program design is that it's a value chain from recruitment to training to supervision. So there's no point, for example, in giving a CHW a fancy phone for really great data collection if they're out of stock of rapid diagnostic tests or anti-malarial medicine. That's why, as Dr. Fred was sharing, it's really important to do both, to have great data collection, to have great supply chain, great recruitment, great training. Unfortunately, what we see is that quite often that value chain is not fully intact. We see community members recruited without testing their qualifications to receive a few days of non-assessed training to then go and work as volunteers, and unequipped, unsupervised, unpaid, they never reach their full potential. And this is too often the case in countries around the world. And it makes sense. So just think about it. If you were running a factory and you didn't equip or supervise or pay your workers, what type of product would you get? You'd get probably a non-existent one. And that's exactly what we see so often, unfortunately, in community health. Too many health systems do not set their CHWs up for success. And as a result, they underperform. But we can, change the story, and we already see that there are places where it is being changed. The National Community Health Worker Program in Zambia is a great example. Same thing in Mali, as described by Shnima. And what this looks like is just taking a few evidence-based actions. I'll give a couple of examples. Number one, accreditation. Ensuring that CHW health knowledge and competencies are tested prior to practicing. Number two, continuous training, making sure that continuous medical education is available to and required of community health workers, just like every other type of medical practitioner, rather than kind of one-off, unpredictable trainings, which again is what we often see. Coaching, having CHWs see a dedicated supervisor on a frequent and regular basis for one-on-one coaching or mentorship, as Dr. Fred described. Payment, fairly compensating CHWs financially at a competitive market rate. Data feedback loops, when we have this great data collection, is it being reported to public sector monitoring evaluation systems? And then is that data used, or are those data used for decision making? At national levels, but also do they come back to the community level? So, workers, folks like Helen, can work with communities to figure out, hey, why is incidence of malaria going up or down, and what can we do about it together? And so these are just a couple of examples, and we'll talk more about these different evidence-based practices and ways to assess them. But in sum, to your question, Marianelli, we know that they're important. because of the evidence. It's not just the right thing to do, it's the smart thing to do. There have been, literally hundreds of rigorous studies at this point that show that CHWs can reduce mortality, reduce morbidity, saving the lives of countless mothers and children and adults. But that can only happen when they're adequately supported. And the good news is that when governments and private foundations make that choice to invest in strong health workforce, they can expect to see a return on investments in terms of better health, economic productivity of up to 10 to 1. So it's a really smart investment.
Wonderful. It's so great to hear about these best practices that through the coalition, I bet you are having this great input that you have from all these organizations doing good work and the ones who still need a lot of strengthening so the work can be even better. So with that, Nima, I see you nodding a lot. I guess you are confirming a lot of what Madeline was saying. So let's get into the details on how the MUSO's community health model works and what makes it successful. I heard this model has been on the news several times. There have been publications about the model, and there also have been prizes that MUSO have received thanks to the type of care that you give. So over to you, Nima.
Thank you, Maria. Yes, I was nodding a lot with Madeline. I think, MUSO and Madeline we work very closely together. And, I believe that there were very key pertinent points about what Madeline said. I mean, there's been a lot of evidence-based studies around ICCM, but it's still lacking. There's really a lot of work to be done. And I think for a lot of reasons, which is, it is important not only to train CHWs, but to ensure that CHWs are paid, to ensure that CHWs are supervised. And what makes our model successful is that we do have a 360-degree proactive model where we recruit the CHWs with community buy-in, we train the CHWs, we equip them with the tools necessary for data collection and to track the care that they're providing, but then we also have dedicated supervision in place to make sure that we're offering the quality of care that is needed in these communities. I will also add that another aspect is around speed as well. And I think that that's what makes the proactive model so successful, specifically and especially for malaria. Health isn't something that can wait. And a key component of our healthcare model is the speed. So our CHWs aim to reach and treat every patient within hours of their first symptoms. So in peri-urban Mali and Urimadjo, 93% of children under the age of 5 are actually treated within 24 hours of symptom onsets. And in our rural sites, 69% are treated, 69% of children under 5 are treated within symptom onset, and 81% are treated within 48 hours. So this is very key when we're talking about addressing malaria, because as we know, the earlier that the malaria can be detected and treated, the better chance for survival. In Mali, malaria is the primary cause of morbidity and mortality in Mali. It is a serious problem, particularly among children under the age of 5. And if we're able to catch and treat malaria cases within 48 hours of symptoms, then we allow for very few opportunities for the parasite to reach new hosts, and we can cure the infection before it reaches deadly stages. So I think what the really two key foundations of our model is the proactive nature of the model, the fact that the CHWs are going to go door to door searching for cases. So we're essentially turning the traditional treatment model, on its head, right? So instead of waiting for patients to come to the health center, our team of community health workers, they're going to go door to door every day, actively searching for cases, and they're going to follow a very rigorous protocol in terms of fever evaluation, in terms of the therapy that we're going to be providing, the treatment, and that active case finding. So I'll stop there, but I think, if there are other questions, I'm happy to delve further into that. Thank you.
Awesome. Thank you so much for that. I just want to add that the Rotary Club of Washington, D.C., where I belong, we worked very closely with MUSO a few years ago in some global grants to actually strengthen the network of community health workers and the medication administration. So it's great to see how this model has evolved even more, and how are you guys doing right now. So let's go back to Agnes. And I'd like to ask you, Agnes, to tell us a little bit about the model called Integrated Community Case Management used in Zambia, so-called ICCMs.
Thank you. Under integrated community case community management or integrated community case management, how it is being monitored, like I would give an example, how it is done in Masaiti. We have a tool that we use for monitoring of how these ICCM, also called the community health workers, in how they are performing, or how they are working their various facilities, as well as in their respective villages. What usually happens is it starts from national level. There's an assessment done at national level. Then it comes at provincial level. That is provincial health office. There's an assessment that is also done. And then from the provincial health level, it trickles down to district health office. Once we assess, the assessment basically is done. What we actually look out for the logistics, such as drugs. Do we have enough drugs to supplement or to support the malaria management? Do we have enough control measures that can help in the reduction of malaria cases? How is the human resource in terms of malaria management? How is in which villages are these people located in terms of the ICCMs? Then it also trickles down to the health facility, where we have we've trained environmental health technologists or nurses that are supervising the ICCM providers. So they're also monitored in terms of how they are faring. Do they have enough drugs? Do they have all the logistics that are needed in the malaria elimination? What challenges are they facing? And then from there now, it trickles down now at community level to just have the one-to-one talk with ICCM providers, how they are working, what are the challenges that they are facing, and how best the district can also come in to help out. So this monitoring is done on a quarterly basis. But despite it being done on a quarterly basis, we also go back on a monthly basis and follow up on those challenges that the facilities, the ICCM providers are actually facing, and be able to attend to them. And during the monitoring of the same ICCM providers, we're also able to provide mentorship. Because from the training, I'll give an example. The time they were trained, that was in 2019. The time they were trained to date, there's an issue of like, they may even end up like forgetting certain things. So as we're assessing them, we're able to ask them questions such as, if a patient comes, how do you manage the patient? Okay, fine. Oh, they're able to explain. If they are kind of lagging behind, you try now to start mentoring them in their weaknesses, like on certain things that they're not able to explain properly. And then after mentoring them, we continue even at facility level now to kind of follow up on the ICCMs. These are the challenges that we found with the ICCM as a supervisor at facility level. Kindly follow up on this, and we'll still continue making follow-ups on how they are faring in terms of service delivery. And then there are certain instances where there are challenges of, I'll give an example of drugs. We have, I would say, limited supply of drugs because of even issues of COVID, where budget allocation has to be split to cover up for even issues of COVID. There, what we've strategized is we've identified ICCM providers that are working from the furthest distance from the facility. And when we have limited supply, we're able to supply those so that community members that are in those areas are attended to in those areas, as compared to them walking longer distances, like 50 kilometers. Some they even walk 60 kilometers getting to the facility. But if we're able to supply the drugs to ICCM that are from the furthest from the facility, then it becomes easier even to manage issues of malaria in such respective catchment areas. And then during this same monitoring and supervision, as well as mentorship, we may put it, we are being supported by the Rotary Club. They're able to support us with the quarterly monitoring of the same in terms of logistics, fuel, and all that. And they're also able to support us in terms of talk time. The ICCM providers, they provide us with monthly reports of which the facility supervisors, like the clinic supervisor, they're the ones that submit the weekly reports. Rotary Club is able to put up talk time for them so that those reports are sent at district and national level as well as provincial level. And they are also provided with funds after the training. The facility supervisors are provided with funds as well as some identified data entry personnel among the ICCM providers are also provided with funds. So in issues of data submission and all that, it's being covered by the Rotary Club International. And other services that they're offering in terms of when we have anything that pertaining to malaria and we may feel ICCM providers, they need that. They have a pipeline, like issues or programs like refresher courses that are in the pipeline where we want to train the ICCM providers so that they are up to date with the malaria management in the district. And then and not only that, with support from the Rotary Club, the monitoring is not just done at a district, it's being done as an integrated program with support from national level, provincial level. So most of the monitoring that is done, especially the quarterly one, is done as a combined effort with support from Malaria Partners International. And during this monitoring, we're also able to evaluate performance and also just look out for things that probably may put our community at risk. And from there, we're also able to say, okay, these people, they need refresher courses. These, they don't need refresher courses. Okay, mentorship, let's concentrate much on these people as compared to these others. But when you talk about ICCM providers, it's voluntary work. They are not paid. And when you talk about issues of sustainability of this same program is also somehow being done by the Rotary Club for it to just sustain. Because looking at our budget as a ministry, we are unable to say, okay, let's allocate this to this. The allocation is there, but it's kind of limited and unable to support the 150 trained ICCM providers. And these ICCM providers that were trained are actually working just in 19 facilities, of which is just a number of facilities. Like I earlier indicated, so we have about 41 facilities. We would also want to have in each facility, we have an allocation of ICCM providers, because all these facilities, they are located in places where they're quite far from the community, and community members really have to walk long distances to reach out to the facility.
Next, thank you so much for giving us this comprehensive background on how the operation actually works. And let's move to Helen. And I want to ask you, Helen, how do you care for your patients every day? Tell us a little bit about your life as a community health worker caring for patients.
How I work as a community health worker in my community. I work for the patients who is sick with malaria. Yeah, they having the symptoms of malaria. That's the first song I do things, and I tested them to find out if it is malaria positive or malaria negative. If it is malaria positive, I treated them, I gave them a cotton.
And when you treat them and you test them, you identify the symptoms, and then you provide medication. And if the patient is not doing very well, what happens?
I do follow-up.
You do follow-ups. And some of those patients, I believe, they may be not in good shape and go to the hospitals, nearby hospitals.
If I do follow-up, I check that person if he is recovered or not. And if not recovered, I refer him to the hospital.
That's great, Helen. And we are later on, we're going to ask you, I know we're mindful of time. We have 12 minutes for the end of the webinar, and we still have to, we want to give a time for questions. So later, you'll tell us one story about a patient that you treated. So hold on there. So let me go back to Fred as we start to wrap up on the webinar, and just let us know what kind of activities do local and international Rotarians do to support the fight against malaria.
Thank you very much again, Maria. Let me give an example. Like I said earlier, most of the Rotarians are people that come in from our respective communities. We're a group of professionals, like in my case, and a few colleagues of mine were in the same club. We have 3 doctors on the club and 1 nurse. So by virtue of our professions, we're able to get involved or get engaged, not only in the project planning, the health, community health assessments, but also in the even in the teaching, the mentorship, and many other areas. But at the same time, we ensure that we supervise the project on behalf of the Ministry of Health, because eventually the community health workers will become part of the Ministry of Health. So we assist in any way. The other members of the club who are also Rotarians in their respective professions do assist. For our international partners, of course, these are the ones that really help us to organize or galvanize the funding for these projects, including this very project. There is a lot that we have learned from our international partners, and we continue to do, and they have provided us with guidance and expertise in project planning. And not only they've also gone ahead to procure the kind of equipment which would normally not be found in this part of the world. So they do that, and every so often or periodically, they would make supervisory visits, including providing on-site internship. They will also be very much part and parcel of the final reporting for the project itself, but also for the monitoring and evaluation. So in a nutshell, each Rotarian brings their own expertise and at the same time help drive the whole project. Thank you, Maria.
Well, thank you to see that. I guess we now can start moving towards the end of the webinar, where we'd like to ask Madeline to briefly speak about ways of strengthening community health workers. We know that your organization, together with USAID, UNICEF, the Community Health Workers Central, and Initiatives Inc. have developed a tool called the CHW AIM. Can you quickly share about this tool and what does it do? What did it do?
Sure, thanks, Marinelli. CHW AIM, and you can learn more by going to that link on the slide, and we can put it in the chat as well. It's basically an evidence-based, easy-to-use quality tool for designing and investing in high-performing community health worker programs. So it can be used to identify design and implementation gaps in both small and national scale CHW programs, and then close those gaps in policy and practice. And we think it's particularly relevant in this moment because, of course, the investments necessary for rapid community response in COVID-19 are pretty much the same as those required to prevent the next pandemic and ensure that services like malaria care are provided throughout. So this tool can basically help identify where those gaps are so communities can respond, build back better, and I'll put that link in the chat.
Thank you so much, Madeline. This is very, very helpful. Nima, can you give us the closing concept, closing words in terms of how can we best approach actually the strengthening of community health workers going forward?
Yeah, thank you, Marianelli. I mean, I think it's important to know that there's a lot of research out there. There's a lot of evidence out there that shows that the deployment of community health workers does work. I think that there's a lot of space for further global advocacy efforts and to really ensure that we can get the buy-in of the various stakeholders that are involved in shaping global health policy so that community health workers can really be an integral part of the policy and the systems that we're putting in place. Just to share a couple of statistics to show how effectively pro-CCM or community health workers works is that we were able to find in areas where pro-CCM was put in place, the treatment, anti-malarial treatment of children from 0 to 59 months doubled from 14.7% in 2008 to 35.3% in 2015. And we're also able to see that in the areas where this has been implemented, that under 5 mortality was at or below 28 to 100 out of 1,000, and in 2015 it dropped all the way to 7 out of 1,000. So I think the evidence is there that CHWs can really make significant impact, and they can essentially transform their communities. And the more that we empower them, not only through capacity building, through effective training, but also through financial empowerment and supervision, I believe, and we at NUSO believe, that we can really make huge strides in the fight for universal health care for all. So we're hoping through global advocacy efforts to get more financing for CHW programs, and to really be able to lean on the extensive research and results that we've been able to find through the community health worker programs that we've seen, not only in Mali, but in other countries around the world. Thank you
so much, Jim. And now our story from Helen. Helen, can you share an experience, an example of how you assisted someone just in time to get treatment and contributed to save this person's life?
January 30th. It was January 30th in the morning, around 10 hours. I received this patient at home. He came with his parents, his grandma, and he was sick. He can't even walk properly. They welcomed them. I give them stools, they said, and they asked them how he's feeling. And they explained to me he's not feeling well. He had headache, stomach pain, and he had fever, and he was even vomiting. And I tested him. That's because those symptoms had its symptoms that it's malaria. And I tested him using RDT, and I tested him. And the results come out, it was positive. It shows 2 lines. And it's confirmed that it is malaria positive. And I give them the medicine, Coartem 1/24 ACT. And immediately, I told him to start the treatment at the same time, the result out. And I advised them to continue the medicine after 8 hours at home. Then the following day, I do the follow-up is to check how he is feeling. And after I check up, the patient was not that okay. And I continue following up until the patient is okay. And after 3 weeks, the parents came to my place to appreciate with an amount of money. So thank you for what you have done to our child. And I say, no, it's fine. I can't collect money to anyone, to any patient, because I'm a trained community health worker. And my thing is to help my community. My thing is to serve my community. Yeah.
Well, Helen, we thank you so much for being part of this unstoppable workforce of community health workers. We also thank you for being a great biker and an athlete, actually delivering care every single day. We'd like also to thank all our panelists for being and their contributions in the fight against malaria and strengthening the community health workers networks. So now we would like to address some questions if we have time. Ariel, over to you.
Thank you, Maria and Nelly. We had 2 questions. I would like to say that one of them was already answered by Helen. They were asking on what was your motivation to become a community health worker, and I believe you spoke on the fact that you wanted to serve your community and you really enjoy providing care for your community. The second question is what is the medication used to treat malaria in Zambia?
Thank you. In Zambia, currently we are using Coatem for the treatment of malaria, we call it ACT. But for complicated cases, like Ellen had indicated, they are able to refer them to the facility or to the clinic. And upon assessment, they can, depending on the assessment, that is especially like when it's severe malaria, they are put on quinine. And like for Masaiti district, we've not yet started admitting patients. So what usually happens, there are certain instances where one can even be put on quinine, but still not very stable. Those are easily referred to another district for further management. Like for Masaiti district, we are referring to Luansha, that is Ron Hospital. We're also referring at Ibenga Hospital, that is Andampongwe. We're also referring to Ndola Teaching Hospital, because the geographical location for Masaiti, it has boundaries, borders with Luansha, Pongwe, and Ndola as well. But for the ICCM, like earlier, she had indicated the ACT, that is Coatem. When she mentioned the ACT, that is Coatem for the treatment of malaria. Thank you.
Thank you so much for answering that question. Unfortunately, we are at time today, but I want to thank each and every one of our panelists and our moderator, Maria Nelly, for leading this group in this great conversation. Note again that this webinar will be is recorded and will be available on our YouTube channel, Malaria Partners International YouTube channel, for viewing again and in full. Also, if you want further information about Rotary's efforts to eliminate malaria or for the most recent trends in malaria eradication, please also visit our website, malariapartners.org.